Okay, well, welcome everyone to our pro seminar. I'm Salman Keshavji, and on behalf of our department and our chair and David Jones, who heads our education committee, I want to welcome everyone to our pro seminar. As many of you probably know, the purpose of the pro seminar is for graduate students to find out more about the field, find out more about our faculty. And this year we've opened it up to a larger group because we have the benefit of Zoom. And so we're really fortunate to have all of you here, so welcome. We're also fortunate to have two just stellar faculty with us, and I'm going to just read their official bios for the record. Many of you know them. Our speaker today is Professor Joseph Ghosn, who is a professor in the Faculty of Arts and Sciences in the Department of Anthropology and in the Faculty of Medicine in our Department of Global Health and Social Medicine. He is an interdisciplinary social scientist who has both theoretical and applied interests. He's collaborated for 25 years with American Indian and other indigenous communities to rethink community-based mental health services and to harness traditional culture and spirituality for advancing indigenous well-being. He does so from the perspective of a scholar who is trained in health service psychology, inspired by anthropology-style interpretive analysis, and committed to participatory research strategies. He's worked on comparisons of indigenous cultural psychologies with the logics of mental health professions, critical analysis of the concept of indigenous historical trauma, collaborative development of the Blackfeet Culture Camp for community-based treatment of addiction, and commission formulation of the Urban American Indian Traditional Spirituality Program for orienting urban indigenous peoples to traditional spiritual practices. He's an enrolled member of the Ani Gros of Ventre Tribe Nation of Montana. He also served briefly as the Chief Administrative Officer for the Fort Belknap Indian Reservation. He taught for a number of years at the University of Michigan, 16 years, where he directed the Native American Studies program prior to coming to Harvard. And at Harvard, he is also the faculty director of HUNAP, the Harvard University Native American program. So we're really thrilled to have him here as the speaker. And as the respondent, we have Professor Byron Good. Many of you know Byron as the former chair of our department. He was chair from 2000 to 2006. He's a professor of medical anthropology in the Department of Global Health and Social Medicine and in the Department of Anthropology. He serves as the honorary visiting professor in the Faculty of Psychology and the Faculty of Medicine at Gajah Mada University in Yogyakarta. He has, in recent years, since 1996, he has focused his research, teaching, and collaboration on studies of psychotic illness and its treatment in Indonesia. His work addresses critical issues concerning the effects of cultural and social processes on onset and recovery from mental illness, strengthening mental health services, as well as on studies of Javanese psychological experience or subjectivity. He's worked with the International Organization for Migration on assessing the mental health effects of the conflict in Aceh, Indonesia, and developing post-conflict mental health services. And his work has served as one model for developing innovative approaches to mental health services in Yogyakarta. We are really grateful to have these two eminences with us today. And so I'm not going to waste any more time, and I'm going to hand over to Joe to lead us through the discussion today. Joe, please.
Thank you, Salman. Thanks, Marty, and to all of our colleagues and staff in the Department of Global Health and Social Medicine. It's really a pleasure to join you today. Thanks for making this possible. Thanks, Byron, Professor Good, for being willing to join us today and to comment afterwards. I'm really excited to hear what you have to say then. I'm just going to share my screen so you can see my slides, and then we'll move along here. Great, I think we're set. I'm going to be talking to you today about the Urban American Indian Traditional Spirituality Program, community engagement, and cultural adaptation in Indigenous health. And let me start, first of all, by saying that I'm talking to you from Cambridge, Massachusetts. As a professor at Harvard and as faculty director of the Harvard University Native American program, we are trying to impress upon our colleagues throughout the university how important it is to do a territorial acknowledgement at the beginning of events like this. So I just want to acknowledge that Harvard University sits on the traditional territory of the Massachusetts people. Just by way of introducing myself, let me say that I'm an academic psychologist. This is important because I'm in the Department of Global Health and Social Medicine, but I'm not a physician, I'm a psychologist. I am clinically trained as a psychologist, but I also do a lot in community psychology. So all of my work has been community engaged. And because it's with Indigenous partners with respect to mental health services and approaches, it tends to be pretty culturally attuned to various differences that have been important. My research interests therefore sit at the broad intersection of culture and mental health, community-based services, and culturally tailored interventions. And as Salman mentioned, I'm an enrolled member of the Aani Grovant tribal nation of Montana. On my dad's side, I'm from the Azure and Brisboe families. On my mom's side, from the Gon and the Crazy families at Fort Belknap. I really have 4 goals for my presentation today, and I hope to talk no more than 50 minutes so that we can hear from Professor Good and also have time for exchange after I'm finished. First, I want to orient you to the American Indian health context. Some of you probably were here for a presentation by Dr. Don Warren a couple weeks ago. He provided a fantastic orientation to the American Indian health context. I'll just touch on some brief pointers today. Then I want to introduce community psychology to you. The reason I want to do that is because part of the goal of this Proseminar is to say something about social medicine and practice. And not being a physician, I'm not coming at this directly through social medicine, but community psychology has a lot in common with social medicine, and I just want to introduce that to you. More importantly, I'm going to report on the development, the structure, and the implementation of the Urban American Indian Traditional Spirituality Program. And in doing so, I want to illustrate the importance of community engagement and cultural adaptation efforts of this sort. So I hope that's clear for us today. Let me start a bit with the American Indian health context. Again, just brief pointers, really centering on and highlighting the impacts of colonization that have shaped Indigenous health today. Really speaking about American Indian and Alaska Natives in the United States, we are the resurgent descendants of Indigenous peoples who were here long before Europeans arrived. Prior to European contact, there was terrific diversity among our peoples, and there remains terrific diversity today. This is one thing we always say, it makes it a little challenging to offer sweeping generalizations in ways that really hold. One thing you do want to know about us is we've had a terrific demographic rebound. Prior to the arrival of Europeans, it's estimated that there were as high maybe as 10 million Indigenous peoples in the continental United States. But through long processes of colonization that included epidemic disease and of course forced subjugation, military pursuit, and those sorts of things, our population really bottomed out around 1890 with just 240,000 Indian people left. Fortunately, we resurged since then. We're in the process of waiting census results that are more recent. But in 2010, there were almost 3 million people on the US Census who identified as American Indian or Alaska Native only, and even more who said they were at least American Indian, Alaska Native with some other race. And for tribal members, which are a subset of these people, we belong to 570 plus federally recognized tribal nations. I said I wanted to highlight the importance of colonial impacts because our experience has been forged through the common set of experiences associated with Euro-American colonization. So the United States is a nation-building project with a deeply racist past. The United States has depended on stolen African labor and stolen Indian land, and we cannot understand the United States or its current arrangements without acknowledging and recognizing this history. When it comes to colonization, we're really talking about the establishment of outsider control over territory and, of course, therefore, over people and resources within it. This in the United States entailed a lot of land and resource theft. In some cases, it still does in various ways. And, of course, the long subjugation of Indigenous populations. The implications of the colonization history for contemporary Indian wellness needs have to do with the legacy of widespread poverty, persistent discrimination, particularly in border towns and proximal to Indian reservations and identifiable Indian communities. We have a series of prevalent mental health problems that are probably best conceived of as post-colonial pathologies. In specific terms, we're talking about high rates of addiction, of trauma, and its sequelae of suicide. There are lots of other mental health conditions, but these are the ones that are most prevalent and probably are folded best in this frame of reference. Because of our government-to-government relationship with the United States, American Indian communities have a distinctive health service ecology. The Indian Health Service is set up to provide health services or to fund health services for tribal members, and this includes urban Indians to a much limited extent, as I'll talk about in a moment. In the context of all of this, then, there's a real strong commitment by American Indian peoples and communities to self-determination, to trying to exercise agency and control over our own affairs in a way that was not possible for a long part of our history after contact with Europeans, but is increasingly so now. As a result of this interest and commitment to self-determination and community control, we can see that American Indian communities are really important sites of therapeutic innovation when it comes to health, and particularly mental health or behavioral health. So if we look at our communities, we've come from a period of cultural decimation historically to a period of cultural reclamation, especially taking place in the 1960s and since, to result in a really self-conscious discourse about culture. Everywhere you go in Indian country, people talk about culture, and they mean our traditional practices as reclaimed, repackaged, revitalized for the modern era. It's also entailed a shift from outright subjugation of our peoples by government bureaucrats, Indian agents, and so on, to a period of tribal self-determination that really took shape in the 1970s, and now really makes itself expressed through community control of treatment programs or health services or entire hospitals. And finally, it's entailed a shift from superficial adaptation of some, beads and feathers like efforts to make certain kinds of health and especially behavioral health programs and services appealing to Indian people, or supplementary adoption of culture and traditional practices, ultimately even to local projects of true therapeutic innovation, sometimes built from the cultural ground up, so to speak, in our communities. A lot of the conversation about American Indian health is reservation focused, in part that has to do with how difficult it is to study American Indian experiences in urban context. And yet the vast majority of American Indian people live off reservation, and high numbers live on reservation, live in urban communities. But the challenge with that is the simple fact that the vast majority of Indian health services are in fact located on reservation. So what we've seen to try to remedy this to a limited extent has been the rise of over 30 urban Indian health programs over these past decades. Major cities tend to have large multi-tribal and low-income American Indian populations or communities. And these urban Indian health programs, often with really limited resources, essentially spin gold from straw in the context of such limited funding to try and meet the health needs of our urban-based populations. For the intents and purposes of our conversation today, urban American Indians tend to reflect pretty similar health profiles in terms of the kinds of problems and challenges that we face, some of the experiences of discrimination and lack of access, and some of the commitments to trying to maintain and preserve self-determination and agentic expression as our reservation-based kin. So we're going to dive more deeply into an urban health context in a moment. I wanted to give a bit of background for that. Again, I said that one of the goals of this Proseminar is to talk about the practice of social medicine. And I'm going to be talking to you today about a practice that is completely in keeping, I feel, with social medicine. It does come from a slightly different origin story, though. And so I want to briefly summarize for you some aspects of community psychology. Community psychology was born really at the Swampscott Conference in 1965. So, we're 55 odd years old at this point. Community psychology really seceded from clinical psychology at that time in the context of the community mental health movement, when there was an effort to deinstitutionalize the mentally ill from hospital settings where they were locked in back wards for good parts of their lives. And this secession was one that really rejected certain medical and biomedical frames of mental illness, as well as the role that psychologists should play. So in some ways, it was a rebellion against the health service role and provider practices that clinical psychology had embraced and endorsed. Community psychology today is recognized as one of 54 different societies within the American Psychological Association. The American Psychological Association has 120,000 odd members. So there's a lot of different divisions and societies, but the Society for Community Research and Action, or SCRAW, is the community psychology club within the APA. It holds national and international conferences over recent years, past decades, say, for the international conferences. There are some 40 graduate programs where you get master's and doctoral degrees in community psychology or combined clinical community psychology. There are a whole smattering of journals that community psychologists publish their work in, but the ones that are probably most central are the American Journal of Community Psychology, the Journal of Community Psychology, the Canadian Journal of Community Mental Health, and Community Psychology and Global Perspective. I'm just picking a few out. There really are a dozen or more that community psychologists would regularly publish in. Our club within the APA is increasingly multidisciplinary. Really, we're united by our approach and our values, perhaps more so than the disciplinary training or background. And so whether it's social workers or people who are in public health, community psychology is done by a range of practitioners beyond psychology proper. So just to be clear, community psychology is not clinical psychology. It's not within the health services frame of reference in which you're engaged in the assessment and treatment of mental disorders or psychopathology. It's not social psychology, which is typically a lab-based experimental discipline where undergraduates are run through experiments in the building that academic psychologists work. It's not cultural psychology of the large cross-national samples that discipline pretty much traffics in. It's its own subfield of psychology that has particular distinctive values and commitments. And those commitments, and here's where I think you'll see the overlap with social medicine. First and foremost, it's really contextualized versus reductive. It's about recapturing social context and power inequities and advancing social justice in the context of long histories of oppression. It tends to be system focused, which is to say it's looking to figure out how to alter structures and systems rather than person-centered. It's less interested in tinkering with people and rehabilitating them. It's very diversity-oriented, as opposed to believing that a one-size-fits-all can solve societal problems. It's strengths-based and looks for opportunities to capitalize on the strengths that all human beings have, no matter what adversity they have faced, rather than deficit-tailored. It's committed to collaboration, more so than kind of expert-driven initiatives, and therefore it's committed to empowerment, working with, as it typically refers to, citizens or people living in communities to help facilitate their solving their own problems in terms that make sense to them, rather than potentially being victim blaming by virtue of centering a deficit model on an individual person. It tends to be very preventative, more so than rehabilitative. It's explicitly and overtly values driven, tends to wear its politics on its sleeve, as opposed to the kind of academic disengagement that some scholarly fields typically participate in. And so you can see, I think, overlaps well with social medicine. It's well suited for anti-colonial wellness initiatives in the way I'm going to be talking about today as well. So close kinship with social medicine, even though it's not really medically driven, but more from the field of psychology. So I hope that helps to explain a little bit of where the origins of my own work come from and how it is simpatico and really overlaps with social medicine. Let me now shift today to talking about the development of the Urban American Indian Traditional Spirituality Program, which, because of the community psychology values and commitments I just described, was really collaborative in its origin. It started with an action research partnership with the Urban American Indian Health Clinic in Detroit. That clinic is referred to as American Indian Health and Family Services of Southeast Michigan. This is one of those urban Indian health programs, of which there are 30 plus throughout the nation, tend to be located in large cities. This health clinic serves the urban Indian population of the Detroit metropolitan area and southeastern Michigan, which is tens of thousands of people, albeit in any given year, the last I recall, maybe 3,000 of those folks came through as patients or clients through some of the different programs. As a health center, it's important to say it does much more than simply deliver health services, though. It's a community hub in all kinds of respects, and really envisions or imagines a wider range of commitment and connection and programming for urban Indian people than mere health services. Back years ago, as I was talking to the then director of AIHFS, we were discussing what we might do together as a collaborative project. And within 15 minutes, we'd hit on the importance of trying to figure out how best to integrate traditional American Indian healing practices into clinic activities. This was important because they had just gone through a needs assessment where some 300 community members had filled out a survey about their health interests and needs. And something like 90% of them said they wanted access to traditional healing in the clinic. And yet there wasn't really an obvious or straightforward way to do that at that time. And so we were essentially commissioned as a university-based research team in close collaboration with an admin team at the clinic to figure out how to go about potentially integrating traditional healing practices into the clinic. And being a psychologist and thinking about behavioral health conditions in particular, that was really the originating point of thinking about behavioral health services in particular, but it sort of branched out, as you'll see, in ways that transcend that or go beyond that. In addition, because as you'll see, we ended up talking about traditional spiritual practices, it was very important for us to pull together a traditional teachers advisory council of elders who were knowledgeable of these kinds of practices who could further guide these efforts. As I'm young and other people on the admin team were not necessarily the ones who would be the most authoritative in understanding the best way to proceed around some of these practices. Traditional spirituality in Indian communities is sensitive. It's sensitive because the United States government made war on our religious practices for a lot of years. Our traditional people who practiced sacred ceremonies were sometimes jailed and could be kept in jail by Indian agents as long as they continued to try to practice these things. So it's been a long battle to fight for religious freedom in the way that American citizens are guaranteed in the US Constitution. And so because of that history, these are sensitive issues. This whole project, therefore, required about 7 years from start to finish. And it also had different phases along the way. And I'll gesture to some of those phases, but there's not time today to tell the entire story in the way that we could in other contexts. So just to start the story a little bit, after this mandate to try to figure this out, we began really trying to survey constituencies in the urban Indian community in Detroit around how best to integrate traditional healing with clinic services. We did focus groups with community members. We interviewed service providers in the clinic. We interviewed administrators in the clinic, and we interviewed traditional healers who were recommended to us by our admin team at the clinic, just to try to find out better what were some of the ways that we might ideally integrate these sorts of practices. And what we found out was that there were key components that people recognized and advocated had to be in consideration for this kind of integration. These included ceremonial participation was a key component. Traditional education was seen to be important. The centrality of culture keepers and their role in this effort was important. And the importance of stressing community cohesion throughout were all key components that people identified through this consultation. In addition, there were some emergent tensions, trade-offs that emerged as one was thinking about how to do this. For example, how to maintain the integrity of traditional healing practices while also recognizing a wide appeal throughout the Indian community in Detroit of alternative medicine more generally. Another tension was how to engage multi-tribal representation for different healing practices versus also maintaining a kind of relational consistency with specific healers so people would feel trusting and comfortable with these healers. So there were these kinds of things that emerged from these consultations. In addition, we interviewed 8 traditional healers and learned a lot from them. But part of what we learned in that process was there's a lot of complexity and nuance to how traditional healing might make sense to be practiced in a clinic setting. We heard from one traditional healer, for example, like, oh, forget it, you can't do it. People need to come out of the city, they need to come into the bush, they need to come into, where reservation people actually do these ceremonial practices to really fold in and take part in them. It was folly to try to do it in the city. Someone else had been recently trained in a form of acupuncture in the ear for treating addiction, detoxification, and so on. And that person was really excited about this and suggested this would be some way to integrate traditional healing. It's just that the traditional healing that this person was excited about was not indigenous so much to North America as within traditional Chinese medicine. A third healer talked about a kind of consultation that she was already doing in some clinics in Canada that involved consulting sacred tobacco and spirits associated with that to get guidance for patients. So there were a range of ideas and perspectives that people put forward. Some of them were irresolvably contradictory, like it can't be done versus it should be done in this way. These were all important lessons. But what was important, I guess, is that none of these consultations resulted in a really clear mandate, here is what to do X. Instead, it was more like the parameters around how you should go about this instead of a clear guidance about what to do. And so at this point in the actual origin, we returned with our university-based research team to the admin team at the clinic and just try to present some different concrete alternatives in light of these findings. I think we had 6 or 7 different ideas that we wanted to float, and of course invited their ideas too, because it was really their program that needed to be addressed. I know that one of these, for example, was we could work with the behavioral health providers and figure out how to adopt, supposed so-called empirically supported treatments for behavioral health problems in a culturally adaptive way, for example. Another idea we had was to do a more formal evaluation of the youth group program that was being run out of the health center. But the one that people were most excited about was when we suggested that maybe we should figure out how to design a traditional spirituality orientation program for urban Indians. And, the idea was, it's a little bit like maybe Roman Catholic confirmation. It's a little bit like a structured curriculum for traditional spirituality 101, if that would be of interest. Well, our admin team seized on that immediately. It was a unanimous decision immediately, despite the fact that I felt like this was probably the least fundable of some of the projects and programs that we were considering. But when it comes to the kind of collaborative engagement that community psychologists and presumably social medicine advocates promote, sometimes it means doing what the community wants more so than what is necessarily fundable or even legible in all respects to some of our professional commitments. So when it comes then to our development of this urban American Indian traditional spirituality program, who was it for? Well, we pitched it as tailored to any interested adult member of the metropolitan urban Indian community who did not already have prior knowledge or experience of some of these spiritual traditions. What was it? A structured orientation to Indigenous spiritual practices. Where would it be? At the Urban Indian Health Clinic. When would it be? Well, it would be 3-hour sessions once per week for 12 weeks. And we started it in terms of an implementation in February of 2016. Why would we do it? Well, the goal was to inaugurate a spiritual devotional life for American Indian participants who were interested in that sort of thing, with the idea that this could be measured through potential wellness outcomes that would be positive for health and well-being. And how would we do it? Well, we really the idea that we would have a socialized participation into the sweat lodge ritual, including key components of the sweat lodge ritual. Here we have a picture of my late father in front of his sweat lodge at Fort Belknap, for example. Now, there were some key important commitments that were important at the outset for us to acknowledge and to adopt prior to even beginning this important work. First of all, it's really important to say that this was commissioned by the AIHFS admin team. This was not something our university team said, oh, this is what you should do. We were really floating ideas and interested in what our partners wanted, and our partners said they wanted this. Second, it was guided very closely by the Traditional Teachers Advisory Council. I told you that these traditional practices are sensitive, and we really had to have knowledgeable elders who would be able to talk to us and channel this energy and effort in sensitive ways. Thirdly, it was developed by Indians for Indians. This is important because there's a wide interest throughout lots of non-native people in the United States in Indian ceremonies and sacred practices. And it's been commodified heavily in the New Age movement. And because of the history of subjugation of our religious practices, this sort of commodification is deeply offensive to most Indian people. And we tend to be really guarded about who we allow to participate in these things so that we can ensure that they're accountable and not marketing or selling or trading and trafficking in these sorts of endangered traditions. So by Indians for Indians. Finally, it was facilitated by a regionally recognized ceremonial leader who helped us to design it, and then other leaders who helped to run the ceremonies themselves. And the ceremonies, because of the location of Detroit, it made sense, despite the multi-tribal nature of the Detroit community, to really center on Anishinaabe and Haudenosaunee traditions around the sweat lodge, which is what we did. We were dependent on ideally a man and woman co-leader for the actual program itself, who would have knowledge enough about these things, but able to follow the curriculum. We structured it as a written curriculum. We wanted it very, very structured, in part so that we could think about in the future possible dissemination to other urban clinics who might have interest in this, and also so that it could be evaluated over multiple offerings. And therefore, it was important for it to be structured. This is also very, very important. We documented in the curriculum itself some very general teachings, but not ritual details. And we did not script or write anything about the rituals themselves. This is really important because that would not be acceptable to most Indian people. And so the curriculum was about some of the general stuff, but not the ritual side of things. And we designed it with a recognized regional ceremonial leader, Paul Surrett, who's Anishinaabe from Michigan at that time. And Mr. Surrett was recommended to us by the Traditional Teachers Advisory Council as the go-to person who could help with this. And in fact, he was a fantastic collaborator with respect to this. We spent almost an entire academic year working with Mr. Surrett around how to translate his knowledge into a curriculum of the sort that we were trying to develop. So those are the developmental origins in collaborative fashion of this project. Now I want to talk to you just a bit more about the structure that resulted from this period of collaboration and effort as we sought to teach tradition in a structured didactic curricular format. Well, the curriculum itself, as I mentioned, was 12 sessions long. It started really with a program orientation, 4 sessions of teachings of various things, a sweat lodge ceremony, 4 more sessions of teachings, another sweat lodge ceremony, and then a community gathering that came to be thought of or called a graduation. There were lots of curricular components to the teaching side of things. There was the introduction to ceremony, traditional prayer, over on the right side, fasting and visions, tobacco ties, different aspects of traditional spirituality that would be important for urban Indian people without any background or knowledge of these things to learn about through this curriculum. You'll notice that I put on the right-hand side near the bottom in red font, drug and alcohol abuse. I point this out because it is the only real instance of this program, despite it being in a health program, despite it really being anchored, originating from kind of behavioral health concerns, of sort of stock, conventional, familiar health style messaging. And it was very light. And the reason it made sense to do this is because when it comes to ceremonial participation in almost every Indigenous tradition that I've ever encountered, drug and alcohol abuses seem to be fundamentally incompatible with sacred and ceremonial participation. So because that was part of the orientation to traditional spirituality, it made sense to say a little bit about that here. Other than that, though, there was not any other real recognizable form of health messaging of the typical variety. We had to build in regular reminders for all participants because, again, coming from a multi-tribal community where over 100 tribes were represented in the Detroit area at that time, everyone can't get what they most might ideally want. And so we had to underscore the importance of tolerance for cultural diversity within the Indian community in Detroit. We were, as I said, centered on Anishinaabe and Haudenosaunee traditions a bit. And so, to be an effective participant in this program, you had to be open-minded about that, even if that wasn't your specific tradition. And so reminding people that was an important commitment was significant. Positive attitudes, that's important ceremonially and religiously, as well as for purposes of a program's effectiveness. Open minds and hearts in general, good feelings, good relationships to other people in the program, and so on. And restrictions with women's menstrual cycles. This is a sacred ceremonial thing that we often observe in our communities around ceremony. I'm not going to go into the details about that. There is some controversy sometimes about this and differences for how people interpret this. But it was one of the things that we had to remind people of as well as part of doing this work. We, as I said, hypothesized that participation in this program and ultimately development of a devotional life of the sort that we had in mind through the program targeted various wellness outcomes. And so, we had measures that we pulled together to try to get at these different constructs. We thought that this participation would result in enhanced cultural identity, spirituality, ceremonial knowledge, and cultural involvement. We believed that this could increase community mindedness, coping skills, social support, and help-seeking attitudes, and that it would result in greater life satisfaction, reduced distress symptoms, and improved emotional regulation. Things that I think you can start to see how that might be reasonable as hypotheses for how this program might enhance people's health through participation. So let me now move then to the implementation of the Urban American Indian Traditional Spirituality Program, which was essentially an attempt to demonstrate proof of concept. It's one thing to map out and blueprint a curriculum and a way you ought to do things. It's another thing to try to do it and to get real people involved and to see what their experience is like. So this was the purpose of the implementation. We undertook a pilot implementation in the winter of 2016. And I've written about this pretty recently, actually. So there are some real details about how this underwent, if you'd like to know more about it. But we were recruited widely in the Detroit urban Indian community for people who might meet the eligibility criteria, which was you had to be an Indian person in the community and you had to have not a lot of experience with this stuff, but be really interested in it. And I think we had 21 different people who filled out application forms to be involved and judged that about 10 of them would be good for the very first run of this, just to test proof of concept. Now, these folks came from different walks of life. A substantial minority of them had real chaotic life circumstances, and that's typical of a population of urban Indian patients in a clinic like this. And so it was probably pretty representative of some aspects of what urban Indian living is like for people. The program itself was coordinated by one of the clinic staff. Her name is Nicole Fox, and she really was the lead person and did a fantastic effort to try to make sure that this would run well, that they could support people, because actually some of the participants needed things to be able to participate, like they needed transportation. Detroit's public transportation is a mess, and people can't rely on it. And so we had to, Nicole had to arrange for transportation to get people there for the sessions. Some people had childcare needs to participate, and so Nicole had to arrange for childcare. There was a meal every single session after the end, so Nicole arranged for that. So, there's things that happen in these urban Indian clinics that are about community building and about relationships and about taking care of people. And this was what Nicole did in just fantastic fashion that helped a lot to make this a success. We identified a couple, Joe and Joan Jacobs, to actually facilitate the curriculum. I think this is like the hardest job that one could imagine for a program like this. They have to be ceremonially knowledgeable. They have to be engaging and warm and able to work well with novices. They have to be accessible and approachable and friendly. And Joe and Joan were perfect. I mean, perfect. So they did a fantastic job of balancing, like trying to follow a curriculum and the structure of the things, the order of things, the way of talking about things, but also being engaging and personable and giving examples. Not an easy task, but they just did a fantastic job. The sweat lodges themselves, as I said, there were 2 of them built in, again, not scripted. The ritual stuff was not part of the curricular materials at all, but the sweat lodges were conducted by a community member named Anthony Davis. And then after the 12 sessions, which you can kind of see on the right, if you want to look at this in more detail, you can get my article, which has this same in there and explains a little more about this. After the end of the 12 sessions, we did post-program interviews with the participants to try to find out more about what their experiences were like and what they were reported as a result of this. So let me just spend a minute on the post-program interview evaluation. My current postdoc, Tony Pham, has been working this year on helping to evaluate these interviews. So, with 10 participants, and actually only 9 were really interested in doing the research evaluation arm of the project. So we had 9 participants, 6 of whom were women, interviewed for this particular post-program assessment. And you're not going to get cause and effect relationship or anything like that. We because it was proof of concept, we did though very much want to get a sense for people's experiences, what seemed to work well, what they valued in it, also what we needed to improve or what didn't work so well. So we really tried to formally assess through this interview, one-on-one interview process, program experiences and suggestions for improvement. We recorded and transcribed all of those, and that's what Tony's been working on this year so far, has been a thematic analysis of these interview responses. And those have fallen into really 2 themes as Tony has analyzed these. The first is the way people talked about the positive impact on their personal well-being of having participated in this program. And the second was the desire for an ongoing program and some of the ways that it could be improved or altered to make that more feasible. So in terms of the positive impact on personal well-being, our participants talked about the improved psychological and spiritual well-being that resulted from their participation in their own experience. And what was interesting, as we talk about in the manuscript, which is under review right now, was that the psychological and the spiritual frames were accentuated in ways that were quite interesting. People didn't talk so much in religious terms, but more in kind of psychological terms about the impacts that people had from the program. And that was a little surprising to me. It's interesting just to see how people react to these things, and the psychological frame of reference stood out to me. They talked about the benefit to the community and especially for their connection to the community and the possibilities for expansive engagement with the community through the program. They talked about an increase in cultural knowledge. I mean, let's hope that that was, since that was really the primary purpose of such a program, and a desire for further learning about these traditions, as well as sharing, not only like actual sharing, but guidance about how to share. Because I think one of the things that when people learn these things, they recognize, they know that these things have been under siege for a long part of history, that there's some secrecy or sensitivity around them, and they were looking for more guidance about under what conditions it was appropriate to share some of their experiences. They desired an ongoing program, so they talked about, in the language that they came to adopt, classes, not sessions in the way we talked about, but classes. They asked for a shift to maybe drop-in classes. Instead of the structured, weekend by weekend accrual of sessions, instead to have, those that would be offered that people could drop in when their schedules allowed. They wanted additional areas of knowledge, like maybe beyond the basics to more intermediate or even advanced at some point. They suggested including more knowledge, maybe about more knowledge holders or perspectives, more kinds of ceremonial kinds of practices, and therefore to ultimately maybe develop a sequence of staged program tiers, basic, intermediate, advanced, that could do more and more over time, so there would be a whole trajectory for how you could learn about these things through a curricular format. So that's where we left it. Not too long after that, I came here to Harvard. I'm not in Detroit anymore. So, at this point, it remains a little bit open about what the future directions might be. But clearly from this sorts of assessment, we're interested in refining the curriculum based on some of these important areas of feedback. Resourcing is a big issue. As I said before, it was probably the project that was the least fundable in some respects of the things we had in mind to do. But as you can see, we're able to pull it together and probably could pull it together again. But Indian Health did have to kick in a good amount of resources for it. And as I said, urban Indian health programs are pretty strapped financially in general. The interview is one way to just kind of get a very casual evaluation, but it would be interesting to offer it again and to expand its offering so that we could do more formal evaluation potentially. Evaluation is an interesting dilemma around these kinds of issues. I say dilemma in the sense that evaluation isn't really for Indian people. Indian people don't really need evaluation results to have confidence that traditional spiritual participation and practice is good for your health. Rather, it's more along the lines of maybe persuading skeptical outsiders, although that's not really the focus either. I think the real focus is funding agencies often want to only fund programs and projects that have some kind of data or evidence around beneficial outcomes. And so I think it's the idea that evaluation, if you get positive results, can help with getting programs like this funded the way other health services and initiatives can get funded. So replication is one of those things that might make sense as the next thing. But of course, this is a collaboration and a partnership. And so I would have to talk with our partners at Indian Health to know more about what the future might hold in this respect. Okay, let me shift then to some final closing words here. Just in terms of the summary of the Urban American Indian Traditional Spirituality Program, there is in all Native communities, in urban Indian communities too, in certain ways, the worrisome challenge of how to reproduce cultural traditions for future generations, particularly when urban people are not always in regular engagement with reservation people where some of these traditions are most closely maintained. And so part of our effort was to develop in a collaborative fashion this structured program to orient urban American Indians to sacred traditional practices. We engaged in this pilot implementation of a 12-session curriculum to demonstrate the proof of concept. And I would say the signature innovation of this structured curriculum was teaching tradition through a didactic curriculum. If one is at home on a reservation with an extended family, the way you learn to participate in these things is not step by step, 1, 2, 3, here's what you do. It's more organic. It's more through the relationships and being folded into these things in your everyday life. But in an urban community, that's often not possible. And so really to make this available in an urban community, if it's to be made available at all, does require a more structured didactic approach. And of course, the ultimate goal behind it was recognizing for an urban Indian health clinic that a program like this might yield beneficial health outcomes that extend to future generations of urban American Indians as well. I said I wanted to highlight community engagement and cultural adaptation. So let me just say a couple words about that. Many Indian communities desire health programs that integrate, include, or even emerge originally from indigenous therapeutic traditions. And I think actually that anti-colonial health research and health engagement and health programming in Indian communities really requires a participatory approach in the development of these sorts of things to work. This is not about me, Joe Gone, coming in with my ideas and figuring out how to make it work. It's about me, Joe Gone, coming in with a set of background and some resources and some facilitation skills and trying to work with partners around how could we pull something together and trying to follow their lead around what would be useful and important and checking in regularly. In this project, we had community meetings with dozens, scores of Indian people from the community coming in to learn about what we're doing, to give feedback about it. And of course, the Traditional Teachers Advisory Council really realizing the importance. So the participatory approach is so important. That's what makes this stuff anti-colonial. Not outsiders coming into any given community with all the right answers, but instead a catalyst and facilitation process of helping to develop something from the inside. Community psychology draws on a 50-year-old disciplinary tradition for doing so. It's not the same tradition as social medicine, but I think it's very simpatico. Researcher commitments to diversity, collaboration, empowerment, and so on can ensure design of relevant and responsive health interventions. This is really the problem, is that sometimes the health interventions that are on offer from outside experts are not seen to be relevant or responsive. And so the interest in trying to figure out how to integrate, how to adapt, and how to develop on our own these sorts of alternatives is part of why this sort of work is important. Indian health programs that are designed in this fashion may frequently include indigenous cultural and spiritual traditions. Part of that anti-colonial approach is recognizing that Indian people are bereft of and have grieved the subjugation of our cultural and spiritual practices. And so the effort to reclaim, to revitalize, to bring back, and to celebrate and promote these things within our own communities has proceeded apace for nearly 50 years at this point. And as a result, there's a lot of this kind of activity now that's understood to be part and parcel of what good health is involved with. And so these things appear all the time when it comes to thinking about behavioral health and healthcare more generally. Such traditions are therefore understood locally as potent sources of good health. And that has to do with spiritual religious ideas and commitments, as well as other ways of framing and thinking about what constitutes good health. The inclusion of traditional knowledge and practices in Indian program development has to be initiated, guided, and implemented by Indigenous partners. And who are local themselves and who know what the community needs. Obviously, this participatory part I can't underscore enough, and I think that's what makes it most in keeping with the traditions of social medicine. And finally, Indian sensitivities surrounding adoption and promotion of such traditions have to be honored. As I said, spiritual sacred stuff is sensitive. And that's why it was so important to proceed with care in the way that we did. And that's always the case when it comes to this kind of anti-colonial alternative approach that will make the difference. I've written a lot about this project and its approach, but a lot of other related projects, whether it's work with the Blackfeet or all kinds of other stuff about mental health services and cultural adaptation and historical trauma, et cetera. Almost all of it's here available for download for anyone who has an internet connection. And on that note, I'm pleased to turn it back to our hosts to move into the next phase of our program today to begin thinking together about what all this might mean. Thank you.
Thank you so much, Joe, for such a fantastic talk. So let's turn over to Byron. And Byron and Joe have been teaching together and talking about these things for a while. So I know that Byron, you probably have a lot to add. Please.
Well, thank you very much, and thank you, Joe. And I'm going to keep this rather short because I know we have a number of people already, just by looking at the chats, who have questions and want to pursue this. Let me begin by saying what a pleasure it is, both in the Department of Global Health and Social Medicine and in the Department of Anthropology, to have had Joe join us on the faculty in the last 2 years. it is an enormous addition to our department. And just hearing today about the work that he's doing, I think is really critical. Mary Jo and I've known Joe going back to the time that he was a graduate student just finishing up and beginning to do his clinical training at McLean Hospital, and working closely with one of our graduate students at that time. And I would just say that what you hear today is something that is probably quite different than what you would have heard Joe when he was just out of graduate school in terms of how to adapt mental health services for local communities, et cetera. And it's clear that he has, if you will, developed his ideas in collaboration with local communities. And by spending a tremendous amount of time in communities and listening, he talked today about his work in urban communities, but he's also worked in more traditional communities. And in a variety of ways, I suspect he could tell us that he has changed his ideas over time, even though he always had a community psychology orientation. It was, I think it's changed a great deal over time. As Salman said, I had the good pleasure of teaching a course in a graduate seminar in the Department of Anthropology with Joe and with Mike Fisher, who I think is also on here today, called Colonial Encounters Post-Colonial Disorders. And I think it's just worth for the academics in this audience, in this group, in this seminar, to point out several sort of key concepts, some of which Joe talked about explicitly, some of which are part of the larger framing of issues here. First of all, simply discussing Indigenous peoples' mental health services and mental health programs in relationship to colonialism is itself an important move. I personally remember in about 2000 being invited with Roberto Luis Fernandez to go to the University of, California for a statewide meeting on cultural adaptations for minority communities of mental health services, and hearing a lecture there, a seminar that was given by a Puerto Rican woman named Lillian Comas Diaz, a psychologist, talking about post-colonial psychology and post-colonial psychological interventions. And it raised the question at the time for us. So some of you will know that Mary Jo and Arthur Kleinman and I, since the 1980s, had a NIMH postdoctoral and predoctoral training program on culture and mental health services that really focused in the early years, I would say, focused largely on issues of culture and cultural adaptation. And one of the challenges I remember in listening to Lillian Comas Diaz was this idea that if you consider in your clinical work, if you consider to think about people as post-colonial people, as people who have been subject in ways to colonization, as opposed to people who are simply culturally different, it makes quite a different kind of orientation, even in one's direct clinical work. So I think that's important to acknowledge. It led us to run a seminar for a couple of years of the Friday morning's topics, and led to the second thing that Joe didn't describe here, but was clearly in the background, was the academic ideas around settler colonialism that have developed in the past, say 2 or 3 decades, but it really, in particular, in the past 2 decades. That is, on looking not simply at the larger category of colonialism, but at the specific category of settler colonialism, and of the relationship between settler colonialism and Indigenous people, and exactly what is the logic of what happens to Indigenous people in a context of settler colonialism. And that's highly relevant to the United States, obviously, as Joe said in a couple of sentences at the very beginning, but it is throughout the Americas, but also in Australia and New Zealand and a number of other settings in which Indigenous people have been subject to loss of land and loss of control of nationhood. And I think it's important simply to acknowledge that focusing on settler colonialism, in addition to the broader issues of colonialism, are important. And much of what goes along with that then are concepts around historical trauma. And again, Joe didn't speak about that today. In our class, we spent quite a lot of time talking about about historical trauma and what that means and what it takes to actually address historical trauma. And then we spent quite a bit of time in the course talking about decolonizing mental health research. What does it mean to actually decolonize mental health research? And I think rather than using the term and theorizing it, Joe gave us an example today, a quite powerful example about doing that. I want to just pose a couple of questions that Joe might respond to before we then quickly open it up for lots of questions that I know are out there. So Joe, one of the questions I know you talk about coming from the point of view of community psychology, but clearly underlying what you're describing is something like a notion of demoralization and remoralization, and a discussion. And I want to ask from your point of view, what is the relationship between programs that focus on revitalization over against, or remoralization over against demoralization, and those that are focused on addressing very specific kinds of mental health problems? And is there a place? And then this takes us to the very classic questions that have been in the field for very many years about, to what extent, how to interact, what's the relationship between traditional healing systems and the development of mental health services, of which you've given one kind of example. But running in this field has always been a question of whether it is better to have, if you will, to have parallel systems that interact with each other versus really trying to integrate into mental health services traditional healers, traditional healing ideas, etc. In particular, when you're dealing with people with severe depressions, when you're dealing with people with psychotic illnesses, etc. To what extent? So I just wonder where you stand as both a community psychologist and a clinician on this issue of when actually you simply want to have good quality mental health services that, by treating people, actually enable the traditional cultural practices to be more successful. When we worked in Aceh, one of the things, we made a decision not to try to combine the two, but we found that basically simply by giving that, we found that a lot of people were highly traumatized because of the war that they had been involved in, and that simply by giving medications that enabled people to sleep, then they could again begin to and lessen some of the panic attacks they had associated with trauma they had experienced, that they were able to sleep and could recover in this that didn't include any of the sort of classic PTSD interventions, et cetera. And so there's always a question in my mind about the efforts to really integrate services versus having parallel services that support each other. So I'm just curious about how you think about those issues. And maybe, given that I know there are people in the chat who have quite specific questions about how what you're talking about might be applied to their local settings, why don't I leave those kinds of questions to others and simply raise these kind of general issues that you might respond to in a very few minutes. and then open it up to others. But thank you very much.
Well, thank you, Byron. I so appreciate that as well. So Salman, maybe I should to respond a bit to this question while we prepared with some of the questions coming in. So, I really appreciate the framing around remoralization, demoralization. This is part of a longer project to try to conceptualize psychotherapy in really broad terms and the degree to which healing traditions around the world incorporate common elements and factors as opposed to what makes them sort of distinctive. And so I do think that a good part of one way we might view culture as treatment or ceremonial and sacred practice as productive of better health and mental health in Indian country is to frame it in that way for, especially academic audiences. First of all, we don't want to lose sight of there are sacred, religious, spiritual understandings of why these things are helpful and productive of good health. And so for most people who participate in them, that's the reason why. It's about proper relationships with beings, spiritual patrons, higher powers who bring about health when you're in the right relationship with them and in the right relationship with other beings throughout the cosmos. And so there's that real reason that I think drives it for people, for whom these things make the most sense. But it's also the case that we can understand that remoralization has the potential to help people for certain kinds of conditions. And this is where I make a distinction between kinds of mental health disorders. Because there are kinds of mental health problems like autism and Alzheimer's and schizophrenia, where the disorder themselves are pretty independent of the meaning we make of them in terms of the way they impact our lives. Like cancer. Whether we understand cancer, how we make sense of cancer doesn't have a whole lot of change on cancers racking our cells in the way that it does. And that's probably true for schizophrenia and Alzheimer's, these kinds. But the kinds of conditions I'm really talking about that are most prevalent in American Indian communities are addiction, trauma, suicide. And I think these conditions in particular are much more heavily mediated by the meaning that we make of them. This is why I feel like they're a kind of class of post-colonial pathologies, or in your and Mary Jo's language, post-colonial disorders that are probably amenable to shifts and alterations in meaning making alongside the sacred and ceremonial stuff that I'm talking about. So whether it's framed as remoralization or transformation of one's identity, purpose, orientation, social networks, and pursuits, everyday pursuits, or whether it's understood in sacred religious terms, I think it all comes together to render rational the idea that this sort of participation can remedy health problems. With respect to the other question you posed about whether these systems ought to be parallel between biomedical and traditional healing or more integrative, I am actually not wedded or committed to any particular take on that. I know that there are longstanding traditions, particularly in psychiatry and mental health, of having parallel systems. 50 years ago, psychiatrists in the Pacific Northwest were talking about involving Indian doctors in helping with their patients around mental health issues that were really separate and parallel too. But there was consultation, there was discussion, there was knowledge and sharing and so on. Sometimes today we see more integrative possibilities. And my approach as a community psychologist is to be really open. If someone came to me and said, we want the latest, greatest empirically supported treatment that have survived RCTs and that look like they're promising around this disorder in our community, can you help us? I would be open to helping with that. Just as much as I'm open to helping with integrative efforts or parallel efforts. To me, what makes these things anti-colonial is whether a set of community partners is interested in, want and desiring and committed to these things. And what they want is what I'm willing to do in the respects and at the limitations, I suppose, of my expertise. So I'm a bit agnostic about those different approaches. I'm more open to collaboration because I think the same program could result in a way that is either anti-colonial or actually neo-colonial, depending solely on whether the community itself is interested in soliciting those particular programs. I hope that helps a bit. I wonder, Salman, if you want to.
Yeah, no, that's great. So there's a lot of questions, but I've noticed that Dr. Dees has asked a couple, and and Jeff King has asked a couple. So maybe we can group them by asking them to actually ask their questions. And then there's a bunch of others that we can read. So Dr. Dees, are you still on and are you able to ask your question? Okay, I don't see Dr. Dees there. So let me just read the question.
Yes, I'm sorry. It took me a minute to find the unmute button.
Okay, fantastic. Please go ahead.
Thank you so much for taking our questions. I have thoroughly enjoyed this and have learned so much. I wanted to know, I'm here at the Porch Band of Creek Indians. We have the Buford L. Rowland Health Clinic. So we are we're not in an urban setting, we're on reservation land. And I wanted to know if this could actually be useful in our health clinic. Could we perhaps adapt this model, do you think, to our health clinic? Because my husband is Henahall at Hisosa, Tallahassee, our ceremonial grounds. And so we have that separate from the health clinic. It's so clinical. So people go to the health clinic to get treatment psychologically, physically during COVID-19 to get shots of the vaccine. But we have our traditions separately. And I just wondered if you thought that it could potentially be integrated, this fabulous program that you've done, in a setting such as ours.
Thank you, Dr. Dees, for that question. It's really good to make your acquaintance, and thanks for joining us today. It's exciting to hear about that work you're doing, very important work. And, you know, I think that there's opportunity, depending on your interest, to adopt something like this, although because this was developed in partnership with the Urban Indian Clinic in Detroit, Indian Health, you know, they would have a say in this. So it's not just up to me about specific adoption of that curriculum, for example, be something we would talk about. But I also want to point out that a different adaptation that I didn't talk about today was in partnership with the Addiction Treatment Program in the Blackfeet Nation. And in partnership with them, we went through a process where we developed a Blackfeet culture camp as an alternative form of addiction treatment. And that's another example of kind of building from the cultural ground up, so to speak, in partnership with the community. And I do think there's different possibilities from a multi-tribal urban community where you've got 100 different tribes represented versus like the Porch Band of Creek Indians, where, you know, you're coming from a more common kinship and cultural community, where the tailoring could be much more locally grounded. And so I think it's really about thinking about what you would want to commission, what you would want to design and develop, and then working together on something like that. Although, if you were interested in adapting something straight out, that might work, but we would have to work with the other partners too, just to make sure that that was something they were interested or okay with.
Okay, great. Dr. King, are you also on? Jeff King?
I am on.
Here, please go ahead.
Okay. Hi, Joe.
Hi, Jeff.
I was just saying that in Denver, and I'm assuming most urban areas, there's an incredible hunger for spirituality, for connection to one's culture. A lot of times the thinking is that, you know, you've been urbanized, and I did a survey way back in the 90s. And these are people that have lived in urban areas since the 1950s, and yet they're saying there's this incredible desire to have spiritual traditions taught in the city and to the youth and so on. So this program really builds on that. And then another comment I made was that in my tribe, I belong to Muskogee Creek Nation of Oklahoma. On Wednesdays at the community center, we would have one of our traditional healers come and tell stories and also answer questions from younger people in the community regarding our traditions, our history, and so on. It was really effective. And I think, you know, what you did there, Joe, is just sort of build on that to bring it more, you know, into bringing the spirituality even more directly into people's lives. So, and one other thing is that we did a marriage and family program with couples in Denver, where we consulted with elders and also elder couples and young couples, and then brought that together, because in urban areas, a lot of times there's family disruption and so on. And we thought, you know, well, instead of getting these kids in foster care, you know, down the line, why not strengthen families so that we don't have, we're not dealing with it further downstream after the problems have occurred. And it was very effective with connecting young couples and older couples to traditional ways of understanding marriage relationships. So I can see how what this program does sort of complements these other programs. But by and large, just to say, when you introduce culture into the program and have that as a foundation rather than adapting it to a Western program, it's far, far more effective, and it doesn't repeat colonization.
Yeah.
Thanks, Jeff. Wise comments, of course. And, the work that I'm doing or did with the Detroit partners, follows in the wake of earlier pioneer work by people like yourself and people of your generation and even older who were engaged in trying to solve problems around how to get appropriate and effective services to our peoples in urban settings that you did decades before. So thank you for that work and for being the shoulders that younger generations can stand on as we look toward these sorts of things. It's just very important. And also what you're talking about with family, it's hard to overestimate the importance of family around the kinds of problems that emerge that we've talked about, like addiction and trauma. I mean, so much of that is traceable to the chaos in some Indigenous families, not all, of course, but some. And so strengthening the family structure in a way that's preventative is exactly what community psychology is completely dedicated to. Thank you for these comments. Good to see you.
So Joe, I'm going to group two questions. One is from Tasha Peltier and one is from Dylan Dressler. Tasha says, can you share how you measured impact? And Dylan says, I'm interested in any positive health outcomes that were tracked by this program.
Well, thank you. We put together measures associated with all the different constructs that I listed out in that one slide to sort of test. Remember, it was proof of concept. So you can't offer measures to, in this case, 9 people who are willing to participate and interpret anything from that. What you're really doing is just trying to see, do the measures seem to be capturing anything? Do people respond to them in ways that you expected? Were there problems understanding them? So, there wasn't substantive outcome information that was really recoverable from our use of the measures in this pilot implementation. But if we were to go on to replicate this, to offer it more times in Detroit, or if there was interest in replicating it elsewhere, then you could start to try to get enough response rates by a number of participants to start to see, what those might be. So in terms of the measurement, we haven't gotten to the place where that measurement was possible. In terms of the positive outcomes, it's really on the interview basis that I reported those out. And, my manuscript with Tony Pham and former graduate students who are involved in this program is under review, as I said. But that reviews in detail those themes of what people had to say. And so that's something that I hope we could share. If you're interested, just email me and we could get something like that to you to answer that a little better. Keeping in mind that people's interview responses after a program, you could worry about response bias, whether they're just going to tell you what you want to hear. I don't think that happened, and we explained in there why I don't think that happened, because people had plenty of recommendations for improvement to suggest. But ultimately, let me just say that this is one of those examples where I'm just overwhelmed by the positive reception and the fact that it seemed to come together. When you're developing in collaborative fashion these really innovative, unusual things, you have no idea up front whether it can even work, whether it will come to, whether you can find facilitators, whether you can find the ceremony people. I mean, just finding the right people seemed almost impossible early on in some respects, but it all came together. And in any country, we know what things mean when it all comes together. So we have an interpretation ready for that. So that's my set of thoughts about that.
So Joe, we have 2 questions from Steve. I can group them. He says, do you imagine that this could be made accessible in a non-clinical setting, such as a spiritual education/engagement program for the urban American Indian community at large, like creating a school? And then he later asks, do you imagine this would benefit an urban American Indian person far outside of their traditional territory and in the territory of other or different tribes?
Thank you for those questions, Steve. I do think that something like this or something, even this, again, this is a collaborative endeavor, and this is not only mine, this is ours with the Detroit. So I can't ever say that, we can give this to just anyone without consulting with the partners. That's an important point. But having said that, yeah, I think this was designed with urban Indian communities in mind that have multi-tribal participation and representation from lots of different traditions. It did involve selecting people who are open to traditions that may not be their own. So that would be a requirement. I don't know how you could do a program that has to make decisions about certain ways to do it, which usually fall to the ceremonial leaders who are going to run things. It would not be my place or anyone's place to tell Anthony Davis, who ran the sweat lodges, how to do a sweat lodge. He's been, gifted. He's been transferred the right to do a sweat lodge ceremony in that way. He does it that way, and that's what they get. So, there are some limitations around how adaptable it can be. And so it has to be people who are in a state of mind where they're open to traditions that may not be their own. Also, a lot of people in Detroit are coming from far away to the Three Fires region of the country, where they are accessing and did access this, even though they're from alternative places and traditions. And so that seemed part and parcel of doing an urban Indian program itself.
So Joe, there's two people's questions I'm going to group together. It's about funding. Tasha says, I'm also interested in how you were able to get Indian Health to help fund this. We have heard from one of our local elders that there is a line item in the Indian Health budget for spiritual cultural practices, but have never been able to find that. And then Joshua wrote, I directed a Salish language institute at the Salish Kootenai College. Our organization supported staff and students to engage in traditional practices, which made me think more about the practicalities of expanding community participation in traditional practices, such as engaging youth more. I want to help expand traditional practices participation and thinking about funding to help expand efforts. What are your thoughts about getting this type of work funded, such as utilizing traditional teaching practices for health promotion or support in Indigenous communities?
Thank you. Yes, the funding is an issue. And so let me clarify, when I referred to Indian Health, I was not referring to the Indian Health Service. Indian Health is what sometimes we also refer to the clinic I was working with in Detroit. So it's American Indian Health and Family Services Incorporated, AIHFS, or Indian Health is how we refer to it. So when I said that it was funded in part by Indian Health, I meant that the clinic itself devoted some of its resources to making this possible, like with the transportation, like with the meals, like with the childcare. That's the kind of thing that has to be supported locally. I also was able to get some funding. So at the University of Michigan, where I was at the time, there was an NIH grant to incubate new ideas. And we got, I think, $25,000 of NIH money routed through the University of Michigan to help us with this collaborative partnership. So, there were some funds available, but in terms of getting a big NIH R01 for this, maybe if there's a way to think about expanding it across a whole bunch of communities, but let me tell you, it's sort of daunting to think about the quality of the science that's required for big time research funding when you're trying to coordinate multiple sites that all have limited capacity around research. That's just the reality in Indian country. And so, I don't really know if that would be possible. The funding issues are serious. In the health science and research world, it tends to be NIH, which is very, very rigid and strict. And that's why I'm not so hopeful about that. But, when it comes to language revitalization, there's other sources, maybe NSF sources, or maybe even non-federal sources that might be available. Language preservation and revitalization is a big area right now. And I know that there are some funds available for that. I don't know how much that extends into the health domain. Federal fundraising tends to partition off domains pretty tightly. If it's health, it's NIH. If it's not health, then maybe it's NSF. Anyway, but the reality is the funds are limited. And I don't actually know about IHS sources other than the NARCH program. NARCH is Native American Research Centers for Health. It's funded by NIH, but administered through the Indian Health Service. And NARCHs are grants to communities, tribal communities, to do research that they consider to be important with partners that they identify and pull into their own applications. I think the NARCH program is probably the most groundbreaking of research efforts in Indian country for the 20 odd years that it's been in, the 25 years it's been in existence. So that might be a way to think about this, but it does require a community to initiate and to pull in enough researchers to do projects that are of interest to that community. There's like coordination, and again, sometimes it's capacity issues that limit the ability to take advantage of those NARCHs. Thank you for those questions.
Okay, then we have a question from Karen, who said, you said people in urban settings since the 1950s are seeking their spiritual roots. Is there a certain age range when the longing presents? And then she later said, I don't know that I worded my question well, but regarding the younger generations.
Well, Jeff King said that. So maybe Jeff, I'll give you a chance in a minute to speak about that, what you have witnessed in your work. I often am not so sure it's always like teenagers. I actually think that in terms of some of the developmental trajectories that our youth are on, that people sometimes come to these traditional ways a little later in life. Keep in mind that traditional notions of human development can vary quite a lot with how developmental psychologists think about these things. So I remember like among I'm Grovant, our kin, the Arapaho, have had a lot of work done with an anthropologist named Jeff Anderson. And I know when Jeff talks about human development with his partners there in Northern Arapaho, that their notion of entering into like adulthood, was pretty later than we typically think of in developmental psychology, like, 40 or 50, you're finally a full adult, not like 20 or 30. So, even the ideas of what's developmentally appropriate can be really different depending on the kind of cultural orientations people are in. But I'll say that I think that the stories you tend to hear about the turn to tradition in a way that can especially remedy addiction, or that people attribute their remedy of addiction to, often happen in more like what we think of in modern psychology as middle age or early middle age, late adult youth. Jeff, I wonder, did you want to speak to the other question about 50s?
Yeah, sure. Of course, the 50s refers to the urban relocation programs where hundreds of thousands of Native people were relocated to urban areas with the promise of success in living and so on, which most consider a failed program. And the research that I did in Denver primarily showed that the older people always had that desire to stay connected to their traditions and so on. The youth did not. They were, according to our research, they didn't really identify as strongly. And it's kind of along the lines of what you said, Joe, is that it's in their 20s when they start asking the questions and kind of going back to, who am I as a Native person? At least that's been, as a clinical psychologist working in Indian country and then also as a researcher, that's what I've seen. It's usually not until their 20s. And then there's that hunger. So,
thanks, Jeff.
So we have a comment here from Imurio, which says, have you attempted to create curriculum or attempted to articulate basic principles and beliefs about health? It seems that much of the curriculum was very basic in terms of culture.
The curriculum was really about traditional spiritual practices, and it was intended to be really, really basic to orient people who didn't have a lot of exposure or access to that in the urban community. So really, so one of the dynamics around traditional spiritual practices in Indian communities that any of us who spent time there know is that there can be kind of a pecking order or a hierarchy about those who know and those who don't. And sometimes those who know exercise their authority by making those who don't know feel a little bit excluded or less aware. And it has to do with, some people might frame it as lateral violence or the way insecurities can play out, et cetera, et cetera. Anyway, for whatever the reasons are, that can be a dynamic. And so the importance of this curriculum was to be so very basic that no one would run the risk of feeling like they didn't know something and therefore feel less than in a way that would alienate them from the program. So, when we started, it was very basic, like, well, what is prayer? How does one pray? Who is one praying to? Those kind of questions, and of course, there's not a definitive answer across all tribes for those kinds of things, but the goal was to at least have some conversation about that, to hear a couple perspectives about that, from very, very basic. Now, when that was about traditional spirituality, as I said, there was very little health programming in this at all. There was, it was really not based on all our consultations of what people needed. It wasn't about like health messaging, how to be healthier in the usual sense that we think about that in biomedical frames of reference. So in that sense, there wasn't much of that at all, either basic or advanced.
Arthur, you have your hand up.
I thought it was wonderful, Joe and Byron, but you did a great job. I did have a question. In part, you answered it, I think, just now. But I did hear in your presentation the term health several times. And I'm just wondering whether it makes a difference in terms of the framing language or the introductory language that's being used by the community psychologists coming in and doing this. For example, does it matter if you use the term health or mental health, or if you leave health out altogether and simply talk in terms of wisdom?
Yeah. Thank you, Arthur, for that question. It's a great question. And I do think obviously those frames have really different implications. They signify different sets of concerns. They might mobilize a different ethics and a different set of passions and commitments. So that's all really important. You know, the reason why health looms so large, I think not just in my own framing of this, but in the way American Indian people often frame these issues. Number one, there's a traditional precedent. So health is a really much more capacious concept, I think, than biomedical notions of health. You know, health and health and well-being are sacred ceremonial ideas, and one's connection to the higher powers or the spiritual beings is conducive to prosperity and well-being that, you know, can be referred to as health in a sense that, again, is quite expansive. I think that that touches down in our modern world around resource access. And so, you know, not surprisingly, the revolution is not going to be funded by the federal government. What is going to be funded by the federal government is not dramatic transformation in structural inequities, but rather, you know, health is a way to leverage access to resources that you can't otherwise get. And so I think that Indian people and Indian advocates often try to play both sides of this particular leverage point around trying to expand our conception of health in a way that Indian people have long thought of it, but also to mobilize health to access resources that are so very scarce and of which we are deprived of so many. I mean, it is the policy of the United States to fund Indian health to the full extent needed, and yet Congress has never allocated adequate resources to really do that. We get 60 cents on the dollar compared to what the federal government provides for employees in terms of health coverage when it comes to Indian health. So I think that's part of the dynamic that's going on. Wisdom is beautiful. I think that resonates with a lot of Indian people as well. I think community psychologists would be really open to that as well. But of course, it just doesn't have the call to resources in quite the same way, unfortunately.
Well, thank you, Joe, and thank you, Byron, and thank you, everybody, for joining us today. It's been a really great discussion. Unfortunately, we're just over the 1.5 hour mark, and I'm loath to have us end, but we must. So thank you so much. Appreciate it.
Thanks, folks. Very good to see you. So long.
Bye.